This is Paul Wise, professor of pediatrics, Stanford University, and my topic is the future of pediatrics. This is actually a wonderful time for young people to be going into pediatrics. I say that not because things are quiet or likely to be stable, but rather it's an opportunity for leadership in creating dramatic change in the profession. That now, more so than any time in the past 40 years, pediatrics is going to undergo considerable change. And the opportunity for young people going into pediatrics is to help create that change and to ensure that that change is in the best interest of children and their families. And I'd like to discuss the opportunity and the kinds of challenges that pediatrics will have to face by talking about 5 different themes, 5 different challenges. The first is recognizing the historic shift in the epidemiology of childhood need. We can see that in looking at some basic slides. This is a slide taken from national survey data in the United States that looks at the average acute conditions that children experience per year. And it's broken into different age groups, children under 5 to 14 years, and 15 to 24 years. Obviously, some of those kids are not exactly children anymore, but that's the categorization that the survey uses. And what you can see over time, really since the early 60s, is there hasn't been very much change in the likelihood that a child is going to have an acute condition in any given year. And when you think about what these acute conditions are, it sort of makes sense. Acute condition is anything that requires a kid to stay home from school or visit the doctor. And so that's ear infections, viral syndromes, sore throats, and the acute conditions really haven't changed very much over the past 40 or so years. It's really quite remarkable. However, look at this slide. This is the likelihood that a kid is going to stay home from school. And while the likelihood that a child is going to have an acute illness hasn't changed, the likelihood that they're going to stay home from school has dropped dramatically. It's less than half than what it was in the 1960s. Now, we don't know exactly why this has taken place, but I'm pretty sure, and all indicators suggest, that an important consideration is changes in maternal employment, that women go to work or in the workforce now more than ever, and that means that there's really nobody to take care of these kids when they get an acute illness. My wife is also a pediatrician, and we have 3 kids, and we usually call it the drug and drop routine. Little Johnny wakes up 3 years old with runny nose and a fever of 101, and we both have patients and meetings and give the kid some acetaminophen or ibuprofen, drop the kid at daycare and tell little Johnny not to mention this to the daycare worker that you're sick, and turn your pager off and pick little Johnny up at the end of the day, sort of drug and drop routine. And there are families throughout the United States that are facing these kinds of decisions. And we feel that this reduction in school loss, days lost at school, is very much a reflection of changes in maternal employment, women entering the workforce. However, there's something else that is also in play, and I'm reminded of that when I work in global settings, places where an acute condition can be, in fact, a terminal illness, in areas where a high fever in a little child could be something extremely serious and even potentially fatal. But in the United States, the broad perception in the American public, among American families, is that a fever, particularly a low-grade fever, in a young child is not likely to be very serious. It's not likely to lead to a serious problem, hospitalization, and certainly not death. And that's because the epidemiology of infectious disease in children has changed dramatically over the past 60 years, and the American public recognizes that. There's been a sharp reduction in serious acute, particularly infectious diseases in children in the United States. You can begin to see why by looking at the next couple of slides. When I was an intern, this is what the immunization schedule for children in the United States looked like. We can actually memorize this. This is what it looks like now. There's been a dramatic change in our ability to prevent potentially serious infectious disease in young children. And that has altered the epidemiology of childhood dramatically, really historically, where a fever in a young kid is really not likely to be associated with any serious problem. It hasn't eliminated it. We know that there are some children who have serious problems with acute infection, previously have acute infection, but that's relatively rare now. And the likelihood that a well child is going to get acutely ill, particularly from an infectious disease, require hospitalization, or have really the risk of death is vanishingly small. And this has been a historical shift that is very much the product of the success of modern pediatrics. At the same time, we've seen a reduction in serious acute disease. We've seen a slow but steady rise in chronic diseases in childhood. The children coming out of neonatal intensive care units, children who would have not survived in prior years, who are now heading out into the real world and out to their communities, may have significant medical sequelae. Children with genetic or developmental disorders that are serious in early childhood sort of ripple across the epidemiology of childhood as they move into community settings, go to school, and place new challenges to the practice of pediatrics in many respects. We begin to see this shift, this historical shift from serious acute disease to chronic disease by looking at a slide like this. This is, again, data from the United States of all children less than 15 years of age, looking at the bed days by the type of admission diagnosis. The bed days is kids who are hospitalized, counting the number of days that they are in the hospital by either a chronic condition or acute condition. And what you can see was chronic condition always had a significant impact on hospitalization in children, even in the early 60s. But there's been fairly dramatic predominance of chronic disease in hospitalization of children, which reflects this shift in the epidemiology. And this is all hospitals. This is not just children's hospitals. If you look just at children's hospitals or major referral academic centers in pediatrics, the chronic conditions really overwhelm acute conditions, that the vast majority of children in these facilities are children with serious chronic problems, many of whom, in fact, the majority have at least 3 admissions in any given year, and about 20% will have more than 7. So this shift in the epidemiology is quite dramatic. And one study done by Barry and colleagues looking at children's hospitals really shows just how powerful this shift has been, that 17% of the inpatient days in the children's hospitals that were examined in this study had no chronic condition, but the vast majority were children with significant chronic problems. And you can see the episodic chronic would be something like asthma, and then single lifelong chronic multi-system chronic account for the vast majority of bed days in these children's hospitals. And so what has happened when you look at the epidemiology of childhood is a kind of dichotomization of pediatric need, that you have the majority of children who are basically well, nobody's perfect, but basically well, with a relatively small risk of ever having a serious problem. At the same time, you have about 15% or so of children who have a chronic illness that account for the vast majority of hospital bed days, mortality, and pediatric healthcare expenditures. There has always been some dichotomization, but the reduction of the risk of acute serious illness, particularly infectious disease, has made this dichotomization even more stark than it has been in prior years. And so thinking about this dichotomization, this shift in the epidemiology of childhood, it has important implications for pediatric practice. The first is that pediatric practitioners are faced with having to increase patient volume in order to maintain physician incomes, but are having increasing difficulty in meeting the needs of chronically ill children. And this is not a surprise because the practice of pediatrics in most community settings were built in the 50s and 60s when acute infectious disease was the name of the game. That it was, these pediatric structures were not set up to take care of primarily kids with serious chronic problems. And pediatric practices, in essence, are not well suited for intense care coordination, collaboration with schools and other related service providers in the communities. And what you have is a relative failure of modern pediatric practice in the United States to be able to cope with children with serious chronic illness. And we see this in the data. This is a very recent study that came out of survey data, children with special health care needs, and what percentage of the children with special health care needs had appropriate quality indicators, that the care that they were receiving met the quality indicators. And what you can see from this slide is less than 20% of the children reported quality indicators that met all the indicators that are deemed appropriate for this group of children. The vast majority had serious quality problems. That this really reinforced what most pediatricians in practice will clearly tell you anecdotally, is they have a very difficult time taking care of kids with serious chronic problems. What they have to do is increase the volume to a really considerable extent of basically well children, reduce the amount of time that they can spend with each child in each family, but tilt towards accepting patients who are relatively well. And what I hear when I go around the country speaking about these issues over and over again are good pediatricians, good people who are turning away children with serious chronic illness from their practices. Let me repeat that. Pediatricians are turning away children with serious chronic problems from their practices. Why? Because their practices are not structured to provide high-quality care for these children. And the pediatricians are feeling forced to seeing high volumes of well children. Moving on, a second impact is that what you see is a shift of pediatric practitioners away from hospital-based management, that the complexity of the patients in the hospital it's not really amenable to a community practitioner rounding in the morning, leaving some orders, and then going to see patients in clinic. What has emerged because of this shift in the epidemiology and the reality of pediatric community practice has been hospitalists. The hospitalists didn't come out of nowhere. They came out to meet a need, a gap that was emerging in the requirements of high-quality hospital care and the ability of community practitioners to provide that care. Third is you're seeing the emergence of alternative well child care structures. And basically you can see this New York Times article, attention shoppers, low prices on shots in the clinic off aisle 7. What you have are drugstores, Walmarts that are providing basic services like immunization, diagnosis and treatment for sore throats, and other things that generally were considered part of basic pediatric practice. That these large companies are recognizing that the dichotomization of pediatric needs has shifted family preferences substantially. If most of the kids being seen by pediatricians are basically well, why would families seek out pediatricians when they can just walk into a CVS and get shots and take basic, traditional basic pediatric problems like viral syndrome, sore throats will be taken care of generally at lower cost. And the data suggests, in many respects, the same quality of acute services. Now, there are many reasons why it's important to go to a pediatric practitioner for continuity and for a variety of other reasons. However, this is reality. And this is a reflection of the perception in the general public and certainly among private sector that the dichotomization is real and that it may not be generally appropriate for physicians to be providing well child care in these kinds of settings. The AAP has fought back and pointed out some of the shortcomings of these walk-in drugstore kinds of alternative well child care centers, but it has been quite difficult to confront the reality, and it has really been a growth industry of providing basic health services in alternative settings. And when you put this all together, my suggestion is that the traditional pediatric practice is increasingly unsustainable in the United States. That trying to see higher and higher volume of well children at the same time demarketing or reducing the ability to see kids with serious chronic problems isn't a sustainable model. That something will have to change. We've all known that the content of pediatric practice is changing very rapidly. That's what grand rounds are about. That's why people use the internet to see what the latest is in taking care of different problems and addressing different diseases. That the content we know is dynamic. But what the epidemiology suggests quite dramatically is that not only is the content dynamic, but the structure of pediatric practice will be dynamic over the next decade. That the structure will have to change to respond to the changing epidemiology and the changing financial structure of healthcare in the United States. That what we need to refocus on in pediatrics is what I would call the strategic expertise of pediatrics. We know that it's wonderful and very rewarding to provide well child care to continue on a continuous basis to families. It's great taking care of families with basically well children. It's extremely rewarding. But reward is not the same thing as providing strategic expertise. What is it that pediatricians bring to the table that is unique and strategic within the landscape of primary care services in the United States? And that is, I would suggest, taking care of kids with serious chronic problems, providing consultative services to kids who are being screened and show up with a questionable screen. In other words, to focus on the things that make pediatricians special. Sometimes people forget, in fact, pediatricians forget, that pediatrics is a specialty. We know that it's primary care in many respects for certain pediatric groups, and that's great. But that primary care is a specialty primary care. And what we may see is a transition of pediatricians to a more consultative role, providing seamless primary care within teams or networks of all different kinds of providers, and providing seamless primary care, specialty care referral systems in the future. That, in fact, pediatrics in the United States may have to, in fact, look like pediatrics in every other country in the world, which is primarily providing consultative services to people who are providing well child care in a variety of different settings. That could be nurse practitioners, family practitioners, PAs, working very closely with pediatricians. But the epidemiology, the evidence about the quality of services, and the ability and the willingness of financial institutions, health insurance companies, and plans to pay physician salaries to pay for well child care suggests that the current situation is not sustainable, and that the opportunity now for pediatrics is to take a lead in shifting in a responsible way the practice of pediatrics to better meet the current and emerging needs of children across the country. Now, that was just theme one. Theme two is also providing an opportunity for pediatrics to enhance its ability to provide important healthcare services. And this second theme, the second challenge, is recognizing the life course precursor management potential of pediatrics. And when we think about what we do in pediatrics, we can begin to see how this may emerge. There's been quite a bit of literature, evidence, new studies showing that things taking place early in life, including in gestation, can have lifelong effects. That whether you're born at a low birth weight, whether you have certain exposures very early in life, can actually influence the likelihood that you're going to have cardiovascular disease when you're 65, diabetes when you're 35. The suggestions are even certain neurologic problems in the elderly population. That things taking place early in life may be important to later expression of adult onset disease. There's also the issue of genetic predisposition, that there are efforts pretty quickly in certain parts of the country to expand what we generally have called newborn genetic screens. And you can see this in an article that came out about 7 years ago in the New York Times when a reporter got her genome screened using the 23andMe genome test, which is not whole genome, but candidate predispositions. But increasingly, the cost of whole genome screening has come down, that there are people who walk into a pediatrician's office with a whole genome screen printout in their hand and have identified genetic predispositions associated with adult onset disease. The question then becomes, what should pediatricians be doing? And what we see is pressure to come up with pediatric management of precursor indicators of adult onset disease. How should a pediatrician respond to the finding of a genetic predisposition for diabetes, for example, in later life? How should pediatricians respond to not only genetic markers, but other biomarkers for predisposition to a whole variety of diseases that may not be expressed symptomatically to much later in life, but there is an increasing burden on intervention much earlier in life. And we see that, and as the pediatric world has had to confront what has been called the epidemic of childhood obesity. If you walk around a pediatric hospital, a children's hospital, and try to identify how many kids in that hospital are in there because they're obese, it's going to be very few. It's only very severe cases that are likely to wind up in the hospital. So what's the epidemic? Why all the concern? It's basically because we recognize that obesity in childhood is associated with obesity in adulthood, and it's associated with a whole variety of underlying health problems, including heart disease, diabetes, and a variety of other health problems. But it's primarily anticipatory in its concern that its impact on health expenditures and morbidity and mortality is likely to be expressed much later in life and not during childhood. There are reasons, of course, to reduce childhood obesity, prevent childhood obesity in the pediatric world because of issues that emerge in childhood as well. But the primary focus, the primary concern is anticipatory. And really, the obesity epidemic and the pediatric response is really the leading edge of what I would suggest is the early management of precursor conditions for adult onset disease. And increasingly, there will be opportunities and increasingly a burden on pediatrics to be able to address these life course precursors in the real world. Now, a third challenge, a third opportunity is going to be the application of adult policy to children. And this is very much a product of the very dynamic financial infrastructure of healthcare in the United States, and the likelihood that it's going to continue to be quite dynamic over the next decade. And the concern about the application of adult policy to children is really because health policy has turned into cost containment policy. That there used to be something called child health policy, and now health policy has really turned into cost containment policy. And the reason that that's a concern for pediatrics, the reason that that tends to generate the application of adult policy to children is obvious in the next set of slides. This, of 2011, is Medicare expenditures in billions of dollars. Medicare is the program for health care for people over 65 years of age. This is Medicare plus Part D. Part D is the pharmaceutical component of Medicare that was added to the Medicare program under President Bush, and the Republican Congress voted it in, and it provides supplemental pharmacy services for Medicare beneficiaries. It's been very successful in doing that. This is Medicaid. Medicaid is the federal program. It's shared between the federal government and the states for the poor. And this is the component of Medicaid that's actually spent on children, that the majority of expenditures in Medicaid are for elderly in nursing homes and adults with serious disabling conditions. And while the majority of beneficiaries in Medicaid are children, the vast majority of expenditures go not to children, but to adults. And you can see that in this kind of setting, what you have are intense incentives for cost reduction in the adult population, particularly the elderly. And when you talk about cost containment, kids sort of fall off the radar screen. They just do not cost very much money. And this has created a situation in the policy world where children's issues tend to be ignored because they're not directly relevant to questions of cost containment. And so what it raises is a fundamental question in pediatrics, which is what are, in fact, the special requirements of child health? Is it okay to apply adult health systems, adult health care policies to children? And if the answer is no, that implies that there are, in fact, special requirements for child health that do not, in fact, apply to the adult world. And you can begin to see what those requirements are from this kind of slide. This is, again, survey data, national survey data, and it plots the health status, fair or poor, the recipients, of the surveyed people, and whether their condition limits their daily activities in a significant way. This is different age groups, and while you can see that there are a certain portion of children that have limiting chronic conditions, or their parents suggest that their health status is fair or poor, by the time you're over 65 and then 75 years of age, that more than half, when you get up to 80%, have some type of serious chronic condition that limits their daily activity. That these conditions, even though there's been an increase in chronic conditions in childhood and has become overwhelmingly important in hospitalization and mortality, that it's still relatively rare in childhood. And when you look at hospitalizations by age, overall, you can see that children account for a diminishing portion of hospitalizations, and you can see that it's really a very small portion of hospitalizations, which of course account for a very important part of all healthcare expenditures in the United States. And that serious illness is relatively rare in childhood when compared to adults. That's issue one. Issue two, that expenditures in childhood are spread across multiple rare conditions. That if you look at who these children with chronic conditions are, these hospitalization, the use of bed days, it's spread across multiple rare conditions, pediatric cancers, sickle cell disease, a variety of other relatively rare conditions, unlike the adult world where the bulk of expenditures in hospitalization are accounted for by relatively few high prevalence conditions like heart disease, like dementia. And you see a distinct epidemiology emerge when you compare childhood to the adult world. Now, what does this mean that you have relatively rare conditions? You have this kind of dichotomization in pediatrics that you don't really see in the elderly and the adult world, and you have expenditures spread across multiple rare conditions in children, but relatively few high prevalence conditions in adults. What does that mean? Well, it means that in childhood, there is a requirement for intense regionalization of specialty care services. Okay, so I'm a middle-aged guy, and if I were going to have a heart attack right now, most community hospitals would be pretty good at taking care of me. Why? It's because they see a lot of guys my age having heart attacks. Okay, that the volume of people having heart attacks is relatively high. But what is the likelihood that they have taken care of a 7-year-old with sickle cell disease and acute chest syndrome in the last year? It's going to be very, very small. They may see one case every 7 years, something like that. This implies that there has to be mechanisms to regionalize referral of children with specialty care requirements. And you have this development of concentrating children with serious chronic problems or trauma into specialty care referral centers that have invested in building expertise, resources, nursing, equipment, and experience to take care of children with serious health problems. That you just don't have that kind of requirement in the adult world. The pressure for regionalized referral systems is not as great in the adult world as it is in pediatrics. This is important in recognizing why the adult health world, the adult health policies may not serve the interests of pediatrics very well. That these regionalized systems of care took 20 years of active building in modern pediatrics. It's been one of the great advances of modern pediatrics. And yet it could, in fact, unravel if we're not attentive to the requirements of these regionalized systems of care. Also, what we're seeing in pediatrics is the convergence of public and private systems of care. That we don't have, as the elderly have, is a full federal Medicare insurance for the elderly. But what we're seeing, particularly in many states, is the public and private systems increasingly converging, where a majority of births will in fact be covered by Medicaid insurance, where we have the marketplaces with the ACA and other kinds of quasi-public programs being implemented. And what we're seeing is a kind of mix, a convergence of the public and private systems in pediatrics in ways that we haven't seen before. And particularly with these new systems coming online, we're seeing increased pressure to create systems for children that share financial risk, pressure to create programs like accountable care organizations and other kinds of systems for the provision of pediatric health services where risk is shared between the primary care practices, hospitals, and at times insurance plans, such that capitated fees will be increasingly important in how pediatric care is financed. Now, if you have relatively rare but very high-cost children in pediatrics, being the dominant epidemiologic format, that you could have several years, particularly in relatively small ACOs or other related kinds of shared risk capitated systems where you have basically well kids and you have 10% of kids with serious chronic problems. But, basically average. But then all of a sudden, you have 2 or 3 kids who were born with very serious chronic conditions at very high cost. Okay, these are rare conditions, but when they hit, particularly a small shared financial risk program, they can overwhelm the financial structure and the whole program can collapse. That it's highly skewed in pediatrics, the financial burden that are implied by different kinds of patients. And if you have a relatively small scale ACO or other kind of capitated system, you're basically providing financial structures based on averages that you could have 1 or 2 kids in any given year that could collapse the system. That there's going to be pressure in pediatrics to create systems like ACOs at much bigger scale than what most pediatric practices are used to. That small pediatric capitated programs will not be able to survive 10 years of the new epidemiology of childhood. That the occurrence of 1 or 2 extremely high-cost children will not these programs will not be able to withstand those kinds of increased costs if you're just working on average systems based on average epidemiology. The relative rarity and the high cost associated with these conditions is relatively special to pediatrics, and it will need to be built into these kinds of systems. We're also looking at the exchanges or marketplaces associated with the ACA, what many people will call Obamacare. This is likely to be in place in some shape or form over the next 10 years. And these low-cost exchanges are intended to provide health insurance to people and families that otherwise couldn't afford buying into the private insurance market. And any program that enhances the ability of families to get insurance, that helps the parents of children get insurance, has to be welcomed. And it's an important component of healthcare reform. However, many of the exchanges, particularly in certain states, have been created to attract the young invincibles. It's the 27-year-old young male with no real health problems who just doesn't see the need to have health insurance traditionally. But because of these new financial structures, are going to require that they buy into one program or another. And so the premiums associated with these low-cost exchanges or marketplaces have to be very attractive to attract these young invincibles, and the premiums are relatively low. However, the benefits associated with these programs are also very low. And while there are a range of different programs, often called the metal programs, you can have bronze, silver, gold, platinum programs that offer increasing levels of benefits, the costs, and particularly the co-pays and deductibles, can be quite dramatic in these programs. And if you have a family with a child with a serious chronic problem, the co-pays and deductibles may be catastrophic. And it's going to be important that these programs that are basically set up for adults not become disastrous for children, particularly children of greatest need. And we have to be cautious that these adult policy applied to children do not undermine some of the potential opportunities that these new financial structures could bring to improve the insurance status of families we most care about. And of course, there may be pressures to de-regionalize. Pressures to de-regionalize. That because the adult world has less incentive to create highly regionalized referral systems, they may create contracting relationships among different hospitals and health plans that are not respectful of the intense requirements of pediatrics for regionalized services. And you may see pressure to de-regionalize where the perfect regionalized system for pediatrics would be a system based on the perfect match of clinical need and clinical expertise. But in fact, these regional systems are increasingly going to be based on financial contracts, contracts that are based primarily on adult healthcare needs, because that's, of course, where the money is, and kids are just thrown into the mix. We have to be very cautious about how these new programs, these new financing mechanisms, what they will do to longstanding regionalized pediatric relationships. Now, there is another emerging challenge that will have increasing importance to the practice of pediatrics over the next 10 to 20 years. And that is how clinical innovation collides with growing social inequality. Now, we know that inequality in the United States has grown over the past 20 years, particularly in young families. And this inequality continues to grow and confronts the pediatric world now more intensively than really ever before. However, we're also living in a period of remarkable clinical innovation. Our capacity to address childhood health problems has never been greater, and it's likely to be even more innovative and more impressive in its capacity to address traditional childhood health threats in the years to come. Yet, how do we understand how this clinical innovation will interact with growing social inequality in pediatrics? It's an important consideration, a critical consideration that we're going to have to deal with in the coming years. And it's worth taking a few moments to explore what this will do to pediatrics, to child health, and particularly to the practice of pediatrics in the years to come. And I'll just begin by looking at an example of a health inequality. You have three groups of people, group 1, group 2, group 3. Similar exposure, but widely divergent outcomes. 3% of group 1 die, 14% of group 2 die, 54% of group 3 die. Similar exposure, but widely divergent outcomes. Now, there could be many reasons why we would get a differential pattern, differential outcomes that look like this, but one potential determinant could be differential risk. That group 1 is low risk, group 3 is high risk. And any serious exposure can give you widely divergent outcomes because of the differential distribution of risk in the population. It could be something simple, like group 1 being young adults and group 3 being frail elderly. And any serious exposure is likely to give you widely divergent outcomes because of differences in underlying risk. And that's possibility 1, is that you have differences in underlying risk. Possibility 2 is that risk can be exactly the same, but that you have differential access to an effective intervention. Group 1 got it, but in fact group 3 did not. And with any serious exposure, you're likely to get differential outcomes because of the differential provision of a highly efficacious intervention. Group 1 got the intervention, Group 3 did not. And we could discuss other potential determinants, other potential factors that could create this kind of differential outcome. But my basic suggestion to you is that there are really only two ways that you can get a differential outcome that looks like this. And that is differential risk and differential access to an important intervention, or both. And we know that they tend to travel together. Elevated risk and reduced access. They're like two birds caught in the same gust of wind. They tend to move together, but they're not the same thing. Now, this example could have been an infectious disease. It could have been a toxic exposure. But you know what it was? It was the sinking of the Titanic. First class, second class, third class female passenger list. Now, what happened on the sinking of the Titanic? Was it differential risk or differences in access to an effective intervention? It was, of course, differential access to an effective intervention. They loaded the lifeboats by class, by deck. You saw the movie with Leo trying to get up the stairwell that was blocked off. That actually happened. They loaded the boats, the lifeboats, by social class. Now, I use this illustration of differential outcome, differential mortality. Well, number one, because it's a great illustration of differential outcome. And number two, is because it's an important reminder that social class can affect who lives and who dies when you least expect it. And when we take this example and bring it back to our concern about innovation and inequality, you can begin to disaggregate the epidemiology, begin to think about the requirements of modern pediatrics in this way. You can look at differential risk in these populations and differential access, but what holds the whole thing together, what is critically important, is the efficacy of the intervention in question. Why does that have to be there? Because if you have an intervention wholly without efficacy, who cares whether there are differences in access to it? It just sort of makes sense. If it doesn't do anything, do you really care whether there are differences in access to it? No. But what happens when efficacy is high? Then things move in the direction of differential access, and differential access will dominate disparities in health outcomes. When efficacy is low, differential access falls away, things move in the direction of differential risk, and differential risk will dominate disparities in outcomes. So when people ask me, well, is health insurance, is access to care important in reducing disparities in child health outcomes? I hate to give them the answer, but the answer is it depends. What does it depend on? It depends on the efficacy of the intervention in question. Because if it's highly efficacious, watch out. Even small differences in access to it can, in fact, create huge differences in outcomes, huge disparities in health outcomes. Now, you note here that there's nothing about social determinants of health. There's nothing here about what's primary care, what's tertiary care, because that's not helpful in understanding or creating dichotomies in understanding how health disparities are created, how clinical innovation relates to social inequality. What's critical is the efficacy of the intervention in question. The fastest way to increase disparities in infant mortality in the United States today is to allow differences in access to neonatal intensive care and high-risk obstetrics to occur. Now, neonatal intensive care is the highest high-tech area, quaternary care area of pediatrics, in fact, of medical care today. It's extremely high-tech, intensive care. And yet, it's the fastest way to create disparities in infant mortality rates and infant mortality has been a health indicator that has been directly associated with social status for hundreds of years. That what is in play is efficacy of the intervention. Now, the reason I mention neonatal intensive care is because what we're seeing is the beginnings of the unraveling of regionalized neonatal intensive care systems based on the ability to pay, based on social status in certain parts of the country. My suggestion is that it doesn't matter if it's quaternary care, it doesn't matter if it's primary care, if the intervention in question is highly efficacious, it's in play in disparity creation. Now, I get a lot of medical students, residents in pediatrics, junior faculty who are interested in going into health policy and are interested in thinking about their careers. And they often come to me with a particular dilemma, that they were motivated going into pediatrics, going into medicine, because they wanted to serve underserved communities, that their primary motivation for going into medicine was questions of social equity and social justice. But their dilemma, and sometimes it can be quite dramatic, is that they fall in love with a clinical subspecialty. They just love invasive cardiology. They just love neonatal intensive care. And they have been taught to believe that their motivation, their concern for social equity of serving underserved communities is irrelevant in the clinical subspecialty that they are now attracted to. That invasive cardiology is somehow irrelevant to the needs of the poor. That neonatal intensive care is not directly connected in meeting the needs of underserved communities. But if you look at the epidemiology and you understand where disparities in child health are being created now, you recognize that that dilemma, that concern is completely unnecessary. I want neonatologists who care about the poor. I want invasive cardiologists who care about serving underserved communities. Why? Because they're working in areas of very real and expanding efficacy. And some of our biggest problems in disparity creation in child health in the United States today are in fact emerging in areas of subspecialties like cardiology, like neonatal intensive care, and a variety of other subspecialties that are critical components of caring for kids with serious chronic illness. It's also important to recognize how it affects the last theme, the last fundamental challenge that presenting pediatrics. And that if you look at public expenditures and you look at what pediatricians and many think of as the very high cost children that we somehow have trouble affording, you can see Medicaid for preterm infants, this neonatal intensive care, that the federal public expenditures on kids who are very preterm, who wind up with long stays in neonatal intensive care units, are basically a rounding error for Medicare. And this underscores the reason why pediatric expenditures is not very relevant in the public policy world, are preoccupied with cost containment. But it also tends to show that we don't need to fall victim of what can be disastrous dichotomies in different components of pediatric care. That we say what we need is not more care for neonatal intensive care. We need it to go into primary care in community settings. And while I'm a strong advocate for enhanced financial resources for primary care in community settings, it's a mistake to pit the needs of neonatal intensive care units against the needs of community practices and community health. That the scale of expenditure here is so small compared to other arenas of public expenditure for healthcare that pitting the needs of one against the other is not a helpful or realistic concern. And this brings me to the last fundamental challenge, is creating a unified public voice in pediatrics. That we have a tendency to create fights among different components of child health care that are completely unnecessary and in the end run are highly counterproductive. Pitting the needs of neonatal intensive care units against community practice is not helpful and in reality has no real basis in the policy world. Another is elevating social causation by diminishing clinical capacity. It's very important to recognize the social determinants of health, particularly of child health. That's very important. But too often, I hear the elevation of social causation of child health problems by diminishing notions of clinical capacity. Well, what we do as doctors are really Band-Aids and is not particularly important. What we need to do is address the social determinants of health. And again, my whole career has been focused on the social determinants of health, but trying to elevate social causation by diminishing perceptions of clinical efficacy is not a helpful, constructive position to take. Why? Because if you undermine perceptions of efficacy, you always undermine advocacy positions for enhanced access to those interventions. People don't think it does anything. How in the world are you going to advocate for enhanced access to it? And when we're struggling to advocate for expansions of health coverage, of expanded access to all forms of efficacious health care for children, particularly poor children in need, it is not helpful to elevate social causation, the social determinants of health, by diminishing perceptions of efficacy in the clinical domain. We need to embrace both. We also need to recognize that we shouldn't pit primary care against subspecialty care. That in fact, what we need to create are seamless integration models between subspecialty, hospital-based care, and primary care, particularly for kids, primary care for kids with serious chronic disorders. That primary care in community settings and subspecialty care in hospital settings have been two worlds operating largely isolated from each other. That has to end. That we need to require a unified system of services, but particularly a unified public voice. The subspecialty organizations need to get together with the primary care organizations and advocate for pediatrics and child health and well-being in ways that we haven't done before. And what I basically are suggesting is that we recognize that we are facing emerging challenges to pediatrics really at a historic level, that we've seen a historic shift in the epidemiology of childhood need, that we've seen an increased requirement to manage precursor conditions to adult onset disease, really embracing a life course perspective in how we see pediatrics and pediatric practice, that we need to be cautious and respond to the application of adult policy to children. And if we're not careful, we're going to see the unraveling of some of the major strides of modern pediatrics because of the improper application of adult policy to children. Fourth, we need to recognize that we are living at a time of enormous, powerful clinical innovation and enhanced efficacy, but at a time of inequality. And we must recognize as efficacy grows, so too does the burden on society to provide it equitably to all those in need. That in fact, efficacy and justice track together. And last, that we recognize that we must create a more unified public voice, that we not fall victim to traditional traps in the way pediatrics has been organized and the way pediatrics has expressed its requirements in the public domain. We cannot fall victim of fragmentation based on specialty versus primary care, fragmentation because of recognition of the social determinants, while others are focused on clinical efficacy and clinical service provision. We must recognize we not fall victim to the elevation of certain requirements over the life course. If people advocate that the ballgame is over by the time children reach the age of 3, what does that do to adolescent medicine? It largely relegates it to palliative care. That is not a constructive view of life course epidemiology or how pediatrics should respond to life course understanding and life course science. We must embrace a more unified public voice, and only when we address these 5 challenges, when we recognize the historic opportunities that are facing people coming into pediatrics today, will we best ensure that our programs, our policies, that the future pediatrics will prove both efficacious and just.